lot of people are put off nerve catheters because they're quite difficult to put in. And people get complications associated with inserting them. With this system, it's a very, very straightforward system of inserting an indwelling nerve catheter, so it works very, very well. So this is where we're from. This is the hospital. It's pretty new, it's pretty big, 44 ORs, 101 bedded intensive care unit. It's the main military hospital in the United Kingdom, so all military service personnel that are injured in action come back to our hospital as well. As we just said, we've got a busy transplantation service. We're a level 1 trauma centre, so the helicopter lands half a dozen times a day. So it's very, very busy. So lots of regional anaesthesia, lots of experience, and lots of learning to be done there. In terms of the e-catheter usage, these are the main places that we're using it. So interscalene, supraclavicular, infraclavicular, peripheral upper limb blocks, femoral and fascioriliac blocks. So what is it? It's a continuous nerve catheter that was developed by Dr. Bansui from Canada and with Pyunk. It's as easy to use as a single shot nerve block, and that's what we're basically saying, that why not give them a catheter when it's so easy to use? It takes away all the difficulty of the old insertion of the catheters. It's very easy for one person to do it, but it's a lot more difficult. Back in the day of feeding a catheter through a needle, taking the needle out over the catheter, there was a lot of dislodgement and a lot of problems associated. Great visibility, and we're going to have a play with the Phantom afterwards and show you what it actually looks like live. So, we've got some components in the packet when we open them. We've got a stimulating catheter. I suppose I'll put one together and show you. It comes out of the box with an indwelling sheath and a needle, and a secondary catheter system. So that's the main components, no messing about. There's a few pertinent things about the equipment, and we'll go over those. Just going to show you guys a short video. So this is the components as they come out of the packet. The indwelling sheath will be over the needle when you open it, so you don't have to worry about putting that into place. There's a few main components of the needle that you need to know about before you start using it. The needle is the Sonoplex needle, so it's got the cornerstone marking, so it stands out as bright under ultrasound as the normal Sonoplex needles do for single shot nerve blocks. Fantastic ultrasound visibility. At the last centimetre of the needle, there's a secondary exit point. That's for priming the sheath. So, and we'll go through that in a second. We'll show you how to prime the sheath ready to use. And what that does is gives you a fluid membrane over the cornerstones. The cornerstones will then give you your ultimate echogenicity. We're then going to go to the indwelling catheter that's inserted finally through the sheath. There's a proximal opening in the catheter, and the whole point of that is if you occlude the distal end of the nerve catheter, you're still going to get fluid flow from the catheter and out of the sheath. So you will not get distal end occlusion, which you can often get with an end exit catheter. So that's the components as you get them. There's a little bit of setting up that you need to do, only a minute or so before you use the system. So a very short video of what we're going to do. This is in one of our ORs. This is where you guys will be giving anaesthetics when you come to visit, so it's all good. And this is inside the OR. In the UK we have slightly different. We have anaesthetic rooms, so we don't put people to sleep inside the OR. They go to sleep, or they have their nerve blocks done in a different area, and then they get wheeled through into the OR. So more expense. We have 2 anaesthetic machines for every single operating theatre. So in a 44 operating theatre suite, that's quite a lot of anaesthetic machines. So assemble all of the components first of all. So we have the indwelling sheath over the needle, the e-catheter, the filter and a mount, and the identifier sticker. What we're going to do is prime all of those components. 1, to remove all of the air from the system, which you would normally do with anything, and 2, just to give you a demonstration. Now we're priming it with blue dye just so we can see exactly how this stuff's working. So this is the e-catheter. This is the final component that gets inserted inside the sheath, and if you see, distal end and the proximal end also infusing. So that's through that proximal exit hole, and we'll come back to that in a second and show you exactly how that works. So the most important part of priming the whole system is basically the priming of the needle. If you don't prime the needle appropriately, you will not get the best image out of that needle. So by priming it appropriately, will give you your best ultrasound image. So what I always do is just pull back my needle just back inside my sheath, so I'm getting good flow, and you'll see there, I pull back my needle, make sure that I've got a good flow of my anaesthetic agent, or if you're not using anaesthetic for your primary block, if you're putting some glucose in so you can stimulate afterwards. And you'll see clearly, prime, pop my needle back in. So that does two things. It primes the cornerstones, and it also gives you a very fine fluid membrane to allow the needle to come out. It comes out very easily anyway. So that's the system primed and ready. So priming the system allows fluid to exit both of the holes, the distal and the lateral opening, which primes the cornerstones, and you're going to get a fantastic image of your nerve block needle and ultimately your catheter. Okay, putting it in. We've said it's as easy as a single shot. So, system's fully primed. In-plane approach, which we always use. It's a stimulating needle as well if you use dual guidance. We personally do in the UK. Nice and visible, good visibility all the way through. We're not going near anything, and yes, it's quite superficial. You're more than welcome to come and put it really, really deep. You can almost get 90 degrees on the needle and still see it perfectly. When you're in place and you're happy with your position, at that point, very simply, I tend to use my finger and thumb like I was putting an IV cannula and just flick it off with my finger. Just flick out your needle. You'll clearly see the needle retracting from the sheath and clearly see both sides of the indwelling sheath. So both components are staying in, so the sheath doesn't move, that stays there. Remembering the widest bore that you've made in your insertion is from your sheath, so you're going to get your intrinsic tissue tone hold on to this sheath. It's very, very difficult for it to fall out like conventional nerve catheters. Insert the e-catheter into the sheath, lock that into place. That's the end of your block, or the end of your catheter insertion. So literally as simple as a single shot block. Once the e-catheter is inside the sheath, you then can pull back and reposition, inject the rest of your local anaesthetic. So you get fantastic visibility for the whole of this system. Some of the components we'll come back to. Proximal opening, distal opening. Remember, unique features. When it's in place, your proximal opening is inside the green hub of the sheath. What this allows is for a distal end occlusion, you're still going to get exit from your catheter. So very difficult to become occluded. So, advantages, why are you going to use it? Well, are you going to faff around putting a normal conventional catheter technique into some of the areas that we use, and in very easy interscalene, supraclavicular, very easy catheters to use, feeding a catheter through a TUI needle, having to remove the needle, lots of complexity involved in it. Very simple technique. It can be performed with one person. You don't need a third hand. You don't have to put your ultrasound down when you're feeding the catheter and retracting the needle, which is very important. So this whole technique is an ultrasound guided nerve catheter. Can you say that with a TUI technique? Because sometimes you're not watching it under ultrasound. And due to the use of the permanent cannula, i.e. the component with the wings, you get the maximum bore size is this. So you'll get no seepage. I mean, we don't see any seepage post-procedure. So people say, why not just leave this in and connect this up to your infusion, and that's your catheter. So there is a point to this. This component on itself could kink. Likewise, the e-catheter on its own will kink. So by putting both components together, Bansui describes it as using a steel framework with concrete surrounding it. So it gives it the rigidity in which you can do whatever you want to do and still inject through your catheter. I don't advise you do that in the patient, but if you wanted to, it would still work. The next question we're always asked is, how do we fix the catheter? So how are we going to fix it down? It comes with wings, just the same as an IV cannula. If you want to sew this into place, you can sew it. I know that in the States, you guys discharge a lot of patients with catheters in. You probably don't want to sew that in and then send them home. So you can use tissue glue to stick that down. My personal method, after I've got rid of all the gel, is to use Steri-strips and a tegaderm dressing, leaving the entry point visible so you can clearly see any signs of phlebitis infection. Very straightforward and simple to do. Sonosite do a fixation device. In the UK we get free healthcare, so we have to cut down on whatever we're putting in for patients or doing. We save money that way. If you're billing, then you may as well use the proper fixation device and add it to the bill. You might make a bit of profit out of it. So this is exactly how I would do it. Fix your whole system into place first of all. Then using your filter fixation device and your fix-along catheter device, just pop that down. So pretty straightforward. If you're sending your patients home, this is probably the easiest way to fix the device down, because they'd be pretty comfortable taking that tegaderm and steri-strips off and pulling this catheter out themselves. So, why are we going to use it? It's as easy as a shingle shot technique, that is it. Increased ultrasound visibility due to the self-priming system and simple handling without any assistance. So, don't take my word for it, come and play with it. Mary's going to come and put one in now, she's seen how to do it. Okay. Ultrasound, you have a lateral and a medial board. Have you used ultrasound for anything, line insertion or anything?
We haven't yet.
No, okay, fine. So, there we go, let's get some gain on this. Okay, Mary, so we're going to pop the needle in through this side. I'll show you first of all. We're going to prime it first. So this is going to be an in-plane approach.
Okay.
We're going to pop the needle in. We need to hold both components together. There's my needle, he says, there. All we're going to do is pop that needle underneath that nerve. So guys, you can clearly see that very, very, very visible across the whole of the length of the stimulating needle. I'm then going to remove my needle. So you can see on this image, it's not as clear as on the image that I did because we haven't primed the system. So this is the whole point of priming the system. You can still see the sheath inside, but not as clear as before. Two-handed, Mary. I don't need an assistant. So then, luer lock into place. There's quite a lot of this catheter sticking out. And there we go. That's one indwelling nerve catheter inserted in seconds. So, right, Mary, it's your turn.
All right.
You left or right-handed?
I'm right-handed.
Okay. Be kind to Mary, she's never used an ultrasound in her life. So just go across the long axis, yeah, straight in. That's it. Don't mind that nerve, Mary, it's fine, he won't scream.
Right there?
Yeah, so every time you can't see your needle, just move your probe a little bit, so stop there. That's it, so perfect visualisation. The tip of the needle perfectly. We're not looking for any nerves. So now take your needle out. So keep that visualisation. Just flick it out with your finger. There you go. Keep looking at the screen. Now you need to bring back your visualisation of your, there you go. Pop that in.
Okay.
There you go.
Twist it or...
So up until 5 minutes ago, Mary had never ever used an ultrasound machine. That's her first indwelling nerve block done, fixed into place. Well done, Mary, way to go. So guys, this is how simple this system is, yeah? So we can take complete novices and teach them to put continuous peripheral nerve blocks into patients in minutes. So very straightforward.